Thank you so much for being here. Today's session is with a special guest all the way from Phoenix, Arizona. We're so happy to have Dr. Uzma Jafri. I would like to introduce her first. Dr. Jafri is board certified in the state of Arizona in the family, geriatric, and obesity medicine. She is locally trained and she is a primary care doctor to residents of multiple care communities and group homes for over 10 years. Her practice is 100% mobile and 100% focused on patients over the age of 65 who need primary, transitional, and terminal care at home. She is a certified medical doctor at a local assisted living, overseeing patient safety, quality, and infection control per state and federal regulations. As adjunct faculty at Banner University Geriatric Fellowship Program, she lectures and precepts medical students, residents, and geriatric fellows. She has been a medical director of a local hospice for several years, using her geriatric training on a daily basis to support patients and their families at the end of life. Her full-time job is raising her 4 children, and her passion is supporting mothers and babies as a co-host of Mommying While Muslim podcast and director of the Gathering Humanity Refugee Baby Shower Program. So we are so happy to have Uzma here with us. Dr. Jafri will be joining us for several other sessions in the future as well. So this is not going to be definitely the last time you will see her at Olive. Welcome, Dr. Uzma Jafri.
Assalamu alaikum. Hello, everyone. Thank you for joining. It's an honor to be here. I'm just so floored by all of the amazing work that Olive Community Services does in California. And I hope that, the rest of the country is watching and taking notes on how this can be done in a really, really direct and effective way for our senior community because I do the work that I do because I saw early on in my medical career as a student that the most important population was not being well taken care of. And that was a culture I was not used to because that is not the culture I was raised in. I'm talking about American medical culture. So that is the reason why I do what I do. All four of my grandparents, unfortunately, died in hospital settings exactly the way they did not want to die. And so I wanted to make sure that no family had to go through that. And that's why I chose geriatrics, which, if you don't know, is a specialty in people age 65 and older. So those of you who say that you're old at 55 or try to pretend that you're old at 70, you're really not. You're my babies. My average patient is about 87, and I have many, many 90 and 100-year-olds, and they are young and kicking and vibrant. And I want everybody to be able to do that as long as possible, as safely as possible. So that's just kind of my brief. And I'm not sure if I should just kind of jump into today's topic. So I'm going to look to Olive Community to direct me on that.
Yes, I will share my screen and your presentation to get you started. Uzma, thank you for being here again. And we'll take questions in the end. Feel free to leave questions in the chat box. I'm sure there will be many towards the end of the session.
Awesome. So I was allowed to choose the topic for today, but please know that any topic that you want to talk about that affects your peers and your population, let Olive know and they can absolutely reach me anytime. I have many, many presentations. I do a lot of education for the community and for future doctors, future geriatricians.
Not to forget
Um,
what we're talking about.
I train, recruit, and teach future geriatricians as well. So we do many, many topics. Dementia is one of the most important ones, only because we're going to see a huge rise in dementia because baby boomers, those born after World War II, which includes my parents, are the largest population of our seniors now at this time. They have all become 65 years old. And for the first time in American history, we have more people over the age of 65 in America than we have people under the age of 18. So I think the majority of our population and its problems are relevant to our society and our culture, and definitely to our Medicare dollars, our healthcare discussions. And that's why dementia, because it makes up probably about 50% of my practice, I wanted to talk about this. I have an entire series, but this is just kind of, if you want to think about it, Dementia 101. So the basics, what is it and what can we do about it? Very, very simple. If there are questions that are outside the scope of this presentation, not a problem. I promise all of those questions can be answered in the rest of the series, but dementia series that I've got. But I'm happy to address whatever we can in the time we have today. So I'll define dementia first. It's a general term for memory loss, confusion, and difficulty performing your activities of daily living. And your activities of daily living include how you move around, like how do you walk? How do you get from point A to point B? How do you dress? How do you shower? How do you eat? So those are like our activities of daily living. And if you're not able to perform them because you are forgetting what to do or you're confused about how to do them, then that is a sign of dementia. Dementia is not a normal part of aging. Not everybody is debilitated or affected functionally by dementia. There are plenty of people who I have had who are the oldest person I've ever taken care of is 107. Um, Sharp as a tack, like no dementia, no confusion, always knew what they wanted. So if dementia is happening, regardless of what age, it's never considered normal, a normal part of aging. And what I like to do, because I am Muslim, I like to reflect on the Quran. There is a mention of us losing our senses. I believe it's in Surah Al-Yasin, where like the palm tree curves, like some of us will forget, what we're supposed to be doing, but it's some, not all. So that confirms to me that dementia is not a normal part of the aging process, and it is a pathology that we're still trying very hard to understand. There are several types of dementias. The four most common that we see: Alzheimer's, this is absolutely the most common. Vascular dementia, so if you have anything like heart disease or heart disease risk factors, which includes diabetes, by the way, folks. So if you have diabetes, hypertension, have had a history of strokes or heart attacks, then you probably are at a higher risk for developing a vascular dementia. Lewy body dementia, which is kind of like a cousin to Parkinson's. Parkinson's is not a dementia, it is a motor disease. And then later on in the process, there is a Parkinson's dementia. So it's not included here in this list. And then there's frontotemporal lobe dementia. This can often affect personality and language ability and often happens in younger folks. We can go on to the next slide, sorry. So how does dementia happen? Basically, your brain cells are dying or they're losing their connections and or both. All right. Now, the type of dementia can determine exactly how those brain cells are dying. So in Alzheimer's, there's a particular protein that's building up, and when it builds up, it causes plaques. It's kind of um, like a scab, and it tangles some of those proteins because there's so many of them will get tangled up, and it disrupts the function. So you have two brain cells like this, and I'm showing my hands over here, and then they have little tentacles that are communicating with each other. And if there's proteins sitting on the tentacles, your communication is barred. It's kind of like the phone lines have come down, or there's something like a rock has fallen on the phone line so that communication cannot happen between the brain cells. In vascular dementia, blood flow is actually disrupted because what happens in high blood pressure, stroke, cardiac patients, diabetic patients is blood flow is impeded to the brain cells. And that's kind of like tiny mini strokes. And on those brains on autopsy, we can see those tiny mini strokes have happened. So that actually damages the blood flow to the brain cells. No blood to a cell, the cell will die. In Lewy body, there's a different type of protein that is clumping and slowing down those telephone lines. And in frontotemporal lobe, you're actually having brain cells shrink in certain areas. That's due to different factors. What are your risk factors? Of course, aging, the longer you're likely to live, the higher your risk is going to be to develop one or more of these types of dementias. Genetics, there is a genetic component to one or more of these. Heart health, and heart health. So the one thing that has not changed since I started medical school is the highest cause of death for Americans in this country, whether you're an immigrant or not, is heart disease and heart disease associated risk factors like diabetes. So that's why it's really, really important to control those things. Head injuries, so that can happen and can give you a higher risk, even if it was an old head injury 20, 30, 40 years ago, puts you at a higher risk of developing dementia down the line as you age. Oh, and then the last one was our lifestyle choices. And that's, have we smoked? Have we participated in certain recreational activities like drugs and alcohol? Those can also increase our risk for developing a certain type of dementia or a mix of. Next slide. Is it genetic? This is a really important question, and a lot of people want to know. So, yes, genetics can play a role, but it is not, there's no dementia that is directly related, except for another one that is a motor disease, which is outside the scope of this presentation today. So, we're not going to talk about it. So, early onset Alzheimer's, and we're seeing this a lot more because, again, baby boomers, you are still babies because you're only 65 or like in your late 60s, so you're still considered babies in the geriatric world. If you're developing dementia or have been diagnosed with dementia in your late 50s, there is a strong genetic component and it's linked to the specific mutations that are listed over here. Your neurologists and geneticists know about them and will look for them, especially if you are diagnosed with an early dementia, they're going to go check for these things. And then that way, your family members can also check, your children, your grandchildren can also get checked to see what their risk is going to be. Late onset dementia is after the age of 65. And again, I would say late onset is anywhere after 75 because, again, I don't think you're really geriatric until you're about 75. But the ApoE gene increases your risk of developing dementia. But just because you are positive for this specific gene mutation doesn't even mean you're going to develop dementia or demonstrate a high degree of dementia at 75 or after. Frontotemporal dementia is more likely to be inherited. Again, these are going to be the genes that your neurologist and geneticists are going to be looking for. I will say that frontotemporal lobe dementia is often mistaken with Parkinson's dementia. So you want to go to a good neurologic center to make sure that they tease all of this stuff out. Vascular and Lewy body dementia do not necessarily have genetic links, but if you have a family history of heart disease, strokes, and again, diabetes, hypertension, then you are at a higher risk for both of these. Your takeaway from here is that genetics plays a role, but lifestyle and environment, your pre-existing health conditions are very, very important. Next slide. So how do we diagnose dementia? Definitely the most important thing is talking to you. We get a full medical history, but we don't like to talk to just the patients. We also like to talk to the families because a lot of times families have noticed years before, hey, something's off. It's not just I'm forgetting my keys and I'm forgetting my phone all the time. There's other things and processes that your family is picking up on, and they really have to sit down and think about it with the doctor in order to be like, oh yeah, I remember that time we got lost, and that's totally uncharacteristic of this loved one of mine. Brain scans will also help us. And specifically, we use MRIs, CT scans, and PET scans. And the way the PET scan works is it's looking at the sugar uptake activity in our brains to look at where is that deficient, because the areas where, I mean, all of our brains should be using sugar all the time in order to process. That's not to say eat a lot of sugar, folks. That's just saying how the cells, all of our cells eat sugar. So in our brain cells, especially, we're looking at where the sugar is not being taken up because that means there's something wrong in that particular area. And based on the area, we can deduce what kind of dementia there is. There are blood tests, again, going back to these genetic tests. And then there's cognitive tests. These are tests to see what our cognitive function is. It's not an intelligence test. So please do not mistake intelligence for cognition. Everybody has intelligence, but some people's cognition, their ability to apply that intelligence to their activities of daily living and functioning, is compromised in dementia. So, dementia does not mean you're stupid. It does not mean you're intelligent. It does not mean any of those things. And unfortunately, I think there is a pervasive prejudice and misunderstanding about that. So, nobody's getting stupid because your brain cells are being affected. That has nothing to do with your intelligence. It again has to do with a cellular function. So we have two exams, both the mini mental status and the Montreal Cognitive Assessment. Montreal Cognitive Assessment is a little bit longer. Mini mentals can be done in maybe 20, 25 minutes in an office setting. And that would be a dedicated visit in order to do that if you are looking specifically for, do I have dementia? And you can do this even with your physician, your family physician, your GP, and then move on to neurology if something abnormal is suspected. Next slide, please. All right, this is really huge, especially for the caregivers out there or people who already are taking care of a loved one who has dementia. The Yes, the person who is going through the dementia is the most important person in the room, but I would argue that equally important is the person who directly loves and cares for them, their primary caregiver. They need to be prepared for the changes that are coming because a lot of times it's hard to parse out what is normal dementia, what is behavioral, and then is some of this being made up? Is this real? Because they can do calculations perfectly. Like they have no problem going to the bank and managing their money. But why is it that they can't get themselves dressed? Like they're doing this on purpose for attention, or they're doing this because they're lazy. And that can be really, really hard. Why are they messing up their medications, but they can do their finances so well, or vice versa? And a lot of times, those questions that a caregiver is struggling with are also associated with a lot of guilt. Oh, how can I think that about my loved one? Like, what's wrong with me? That I don't trust them. But it's really hard because it's a 24-hour job without any vacation with no break. So you're going to be going through some of these questions. So I wanted to prepare just a very short slide about some of the changes that you can expect. Memory loss gets worse with time. There's absolutely no uh, uh, padding that or making it prettier or sweeter. Memory loss gets worse because when brain cells die, they don't come back. So it can start with forgetting names, places, and recent events, but towards the end, they may not even remember you. And that can be really painful because you've been a lifelong partner, kids have been there their whole lives. And it's like when they're starting to forget their firstborn's name, then we know that this is a serious problem. It can be very devastating for the family that's taking care of them, but this is not the patient's fault. This is just something that we expect to happen. Changes in personality and behavior are very, very common in some dementias more than others. I forgot to mention that nobody has only one kind of dementia, especially in America where we eat a lot of processed food. Everybody's going to have some component of vascular dementia. And then um, because all of us tend to have a certain protein depositing in our brains, at the age of 65, I argue that everybody has Alzheimer's dementia. If you have a genetic component or lifestyle factors that put you at a higher risk of developing dementia and it's showing to everybody else, then you're going to have a predominance of Alzheimer's dementia with probably some kind of vascular. So everybody has like a mix. At least Alzheimer's with vascular, or maybe frontal temporal lobe, or maybe Lewy body, something like that. So nobody has just one. So I forgot to mention that. So changes in personality behavior can happen first in some types of dementia and then later in other types of dementia. And that can be from anything from severe withdrawal and like not doing anything, not moving, not talking, to being very violent and very aggressive. And dementia, again, is a cognitive thing, it's not a motor thing. So they can be very strong and not understand their strength anymore and not have the filters and social filters that they used to have. And so you can see mood swings and uh, things that are completely out of character for this person that, again, it's very hard for a caregiver not to take personally. Paranoia is really common. Anxiety are very, very common. Difficulty with daily tasks, expect that to get worse. That's kind of how we stage certain types of dementia when you're not able to cook, dress, manage money, give yourself your own medication. So that's kind of how we have performance scales to measure that. Communication challenges. So it can be harder and harder to find words and follow conversations. This is why it's really, really important to make sure we get our hearing checked. Because a lot of times people who are hard of hearing get misdiagnosed with dementia or pseudodementia, and all it was they couldn't hear. So we want to make sure that their hearing is optimized, their vision is optimized, because any kind of sensory deprivation will also put you at a higher risk of developing dementia. So you could be a kicking, rocking 87-year-old woman, but because you've lost your hearing and you haven't invested in hearing aids because you don't want people to know that you have hearing problems, well, you're getting left out of conversations more and more. People stop talking to you more and more. Those brain cells aren't firing anymore. So when they're not exercising, you're going to start seeing cognitive changes and a pretty quick onset of dementia. At 87, you live so long without it. And now suddenly in the next 3, 5 years, you're going to be diagnosed with dementia as well. So hearing and sight are going to be super important to protect. Disruptions in sleep and routine are really normal. As we age, this absolutely happens. We sleep less at night and we sleep more during the day, little cat naps. And this can be very bothersome for some people. And they think there's something wrong with me because I'm not sleeping 8, 10 hours a night. Our brain cell waves change as we age. So we're not supposed to sleep all night long anymore. As long as you're feeling rested, as long as you're able to complete all of your tasks that you want to complete, and you're not sleeping in at night is not interfering in your lifestyle, that's fine. But then you have a brain with dementia and they're not sleeping and maybe they're acting out or they're wandering and the caregiver really needs sleep at night. So they're wanting something done about this and they will be at wit's end. It's a very common reason for a person with dementia to be moved out of the home only because the caregiver can't sleep at night. And they're exhausted. They really can't work 24/7 and maybe they don't have the resources to get help at night. So that's why these disruptions in sleep and routine can have very long lasting, very significant effects. Alrighty, next slide, please. Can dementia be treated? Well, we do have medications, thankfully, alhamdulillah. We're seeing people living longer and longer. So when I first started medical school, from the time of diagnosis to the time of death in dementia was 12 years. Now we're seeing 20, 25, 30 years, and not 20, 25 bad years, 20, 20, probably like 20 good years out of 25, where we can keep people functional longer despite the diagnosis of dementia. So we use the first line drugs are still the first line drugs, cholinesterase inhibitors. This is what's commonly known brand name of Aricept. We have patches as well. And what they do is they don't stop the disease, but they kind of put a brake on it and stop you at the level you are. And the earlier you start, the better there is. We don't think that there is any kind of tolerance developed to these drugs. So the earlier you begin, the more likely you are to be able to preserve your function and your life expectancy. We also have NMDA receptor antagonists. Memantine is the brand name of those, and that's another one that will slow the symptoms, your progressive memory loss that we see with dementia. Lifestyle adjustments are I think, cornerstone of dementia treatment. So healthy diets, the Mediterranean diet. There's a reason why people in the Mediterranean, they have a lot of blue zones over there, which means the most people living over 100 years old or at least up to 100 years old because they have those really high good fat diets and low processed food diets, low sugar diets. They're very active. They're usually in pedestrian communities where you have to do a lot of walking. Cars are really kind of an anomaly in those villages and stuff. Social engagement is really important. Brain exercise is really important. So puzzles, learning new skills. I used to be taught when I was a kid that you can't teach an old dog new tricks. That's absolutely a lie. Old dogs can learn as many new tricks as they want to. They just have to want to. And you guys are all here at Olive Community Services learning new things all the time. So kudos to you. You're already doing half of that work. And then we have emerging treatments. We have new drugs that are targeting those proteins, those scabs, those rocks that are falling on the telephone lines between our brain cells. So we have new treatments coming up for those. We do not have a cure. So, when people ask me, when I diagnose them with dementia or they come to me with dementia, they're like, am I dying? And I'm like, well, yeah, we all are dying of something. You're just lucky. You already know what you're going to die of eventually, but you're not dying today. Again, we can give you 2 to 3 decades now with these new drugs, and you can give yourself 2 to 3 decades by doing those lifestyle adjustments and managing the progression and symptoms of dementia. Next slide, please. So these new things on the horizon, if anybody's been doing the research or looked these up, they're what they do is block the amyloid plaques. That amyloid is the protein that is falling on the telephone poles and preventing brain cells from communicating with each other. So the ideal candidate is somebody with early onset Alzheimer's, so before 65, or mild cognitive impairment, where your doctors notice something's wrong based on initial testings, but they can't diagnose you yet with Alzheimer's. Either your brain scans are fine or your scores on your cognitive tests are not quite definitive yet. So they'll diagnose you with mild cognitive impairment. So it's a good idea maybe to try these drugs at that time. People who have confirmed amyloid plaques, which means they've had the brain scan, the PET scan specifically, and they've had a spinal tap to prove that there is amyloid in there. So if we know what it is, then we can send in a drug to target that thing. Individuals that are functioning and value their independence and are like, yeah, I don't ever want to be compromised cognitively, like, or functionally, like, help me stop this for as long as possible, as early as possible. And people with major health risks like stroke, cardiovascular disease, and bleeding disorders are ideal candidates. But these drugs are not for people who are already late stage, like they're already either compromised in some of their daily functions or their independent functions, people with non-Alzheimer's dementia. So this is really, you have to be heavy on the Alzheimer's part. While I said there's mixed dementia, you want to be heavy Alzheimer's, not like heavy frontotemporal lobe, because these drugs have not been proved in frontotemporal lobe because it's a different type of protein that's depositing there. And people who are at a high risk for swelling or bleeding into their brain. And this is going to be discussed with you with your doctors because, some people are on blood thinners, some people have certain genetic disorders that put them at a higher risk of bleeding. And so that's going to be on a case by case basis. But basically, if you have those things, you're not going to be a candidate for these drugs. Next slide. So, dementia is the result of brain cell damage that happens over years and years and years. So, it can, if depending on if you have the genetic mutation is like actively working, you're going to be doing this for years before you ever get diagnosed, or it can be due to different causes. Early diagnosis is key to managing the symptoms, managing expectations, managing treatment, and any lifestyle modifications that we can intervene with early. Healthy lifestyle choices, the earlier we start, the less likely we're going to have early onset dementia, the less likely we're even going to have late onset dementia. But healthy lifestyle choices, so being active, low sugar, low inflammatory foods, good high fats, because fats are necessary. They kind of cushion those telephone poles to communicate with each other in our brain, our telephone lines. And then we're constantly doing research in dementia. We're trying to get better. Again, researchers, scientists know that this is really the most important research that we can do right now because our population, again, is leaning on the older side, and it's really important to address it so that we have adequate health care and adequate care to take care of people with dementia. So that's really the end of my presentation. I would love to have questions and entertain any questions that you have after everything that I've said or anything that you came with to want to ask about dementia. It can be as specific or as general as you want, and I'll do my very best to answer what I can and come back and answer more at the next one.
Uzma, for that very insightful presentation that really covered the 101 part about understanding dementia. There is a question in the chat box that I would like to share with you. What if a person is very sensitive to medication? Are these medications tolerable?
So if they're talking about first line drugs, there are side effects. So all drugs are poison, right? So all drugs have side effects. But, I take it with a grain of salt when people say that they're sensitive to medications because a lot of times what sensitive means is I had side effects. Well, we knew what the side effects were. So you experience the side effects. That doesn't mean you're sensitive. A lot of people tend to think and I love every human being is special, but you're really not that special because to actually be allergic to a particular drug like takes a lot. And you being sensitive is not an allergy. An allergy is actually life-threatening. So to not take a drug because I had some GI side effects that I was told to expect, maybe I wasn't told to expect, but it's on that package insert with the drug. Um, to not take the drug because of that, I feel like is a really big miss because with time and with proper administration and slowly getting aboard a drug sometimes, because everybody's different and every body is different, right? So I'll say with cholinesterase inhibitors, the Aricept, our first line drug that we give, common side effects that we get are GI, so abdominal cramps, abdominal pain, sometimes some vomiting and diarrhea. I have never seen vomiting. I have seen nausea, diarrhea. And then the other thing that I think is really important is nightmares. Um, so some people experience nightmares, not just nightmares, but like violent, really, really scary nightmares. Okay, fine. Let's not take that. Or let's not start at the 10 milligram dose. Let's be really chicken. So I always promise my patients, I'm the biggest chicken out there. So I'm not going to try anything, especially if you're also scared. Let's do this slowly and let's do this scared together. So we'll start at 2.5 milligrams. This is a drug that's taken at night. So if you're likely to have side effects or if you're sensitive, take the drug at night. You're going to sleep through the side effects anyway, so that's good. If it's GI side effects, probably not. So that's why starting at a lower dose is good. Maybe doing it every alternate day until you are like, okay, nothing happened. So now let me go to the full dose every other day. Now let me go to the full dose every day. Then let me go to the dose and a half, or the 7.5. I don't know if you can do 7.5 with Aricept. I know you can do 2.5. I know you can do 5, and I know you can do 10. There are marketed, and neurologists will often use a 23 milligram version of this. There's a new drug that is also a combination of the cholinesterase inhibitor and the NMDA drug, the memantine. These are expensive, and they're not necessarily proven yet. And the more we combine drugs, the more likely they are to have side effects together, which is why I prefer to take them. I'm very old fashioned and again, a big fat chicken. So I like to take everything very separately, very slowly, and work with you, especially if you, I think, believe that you're sensitive, because I don't believe you're sensitive. You believe you're sensitive, but I will support you. Then we can do things slowly in order to get, the full effect of the drug, which is 10 milligrams that's proven once a day to delay memory loss and symptoms of dementia over time. But yeah, I'm sorry, I take the sensitivity to drugs with a grain of salt, especially when there's so much benefit to be achieved. I mean, this is your life and your lifestyle. And I want to see people living independently for as safely as possible for as long as possible. And if this is a drug that's going to help me do it, give me two, you know?
Another question that came up is dementia reversible? What can we do?
Is dementia reversible?
Mhm.
Okay. Ooh, this is like my soapbox. Ugh.
गाड़ी
There
में
are
है
there are types of dementia that are
ये गाड़ी में
reversible.
वॉकर है
There are types of dementia that are reversible. Those are typically autoimmune, infectious, meaning there is an outside agent that is causing these symptoms. Those are 100% reversible. What we're talking about today, which are the most common cause, are not reversible. So if you've gone to the doctor and you've got a diagnosis of dementia, that is run of the mill, nothing special. Infectious causes have been ruled out, inflammatory causes have been ruled out. Then you have an irreversible dementia. And that's probably what is going to cause you to die one day, a long time in the future, if you follow the doctor's advice, therapist's advice, all of community services advice on how to delay that and to preserve your function and your independence. Did I answer that?
You
Okay.
did. Yes, you did. And I love the pitch of Olive. I hope people are getting it, like how much attending, many times people do ask us, like, does it make a difference if I come out and attend these type of events? And then that's a part of our work is educating, spreading the awareness because they don't see and understand it's not one class, it's just socializing, coming out, learning new things, and really challenging your brain. Which leads to my next question. What are your thoughts on brain games for prevention in addition to diet?
Absolutely. That's part of the lifestyle thing. So that's exercising your brain. I think there's been some research done on Sudoku. So for those who like Sudoku, my dad got me into it and I was like, good, you're doing this work. Like this is really important. Crosswords, all kinds of puzzles. So when I go into dementia units, often these are the activities people are engaged in because again, we're trying, fine, you're in a memory unit, but that doesn't mean we give up on you. Like we still want you to keep the functions that you have. So we're offering those brain games and cognitive puzzles. There's a lot of trivia. So, I'm going to make a pitch to do like trivia with your peers for, when I do junior trivia with my kids, it's all like cultural stuff that they know, pop culture that I'm completely too old for and I don't understand with them. But if I did it with my peers, it would be really amazing. And I think it would be so cool to have a senior trivia night or something pretty regularly to kind of exercise. Okay, like I know these facts, like these are facts that I know. Let's like keep testing myself on them. Puzzles are the same way. Sudoku is kind of the same way. I know how to do math. I know how to do patterns. Let me make sure that I'm still on top of it because if there comes a point where I'm consistently not able to, hey, maybe something's wrong and I should go to the doctor and say, is the acetylcholinesterase inhibitor enough for me? Do I need to add something to my regimen in order to delay symptoms? Because I'm not able to do these puzzles that I was very easily able to do a year ago, 6 months ago.
And recently we were at a health fair, Olive's first health fair involvement, and we were able to do mini mentals. One of our
Oh,
staff members was able to do that. And it takes just 5 minutes. And, it's something, it's a small screening, but it goes a long way. Next
absolutely.
question. Can you touch on lifestyle changes that help? I know you've mentioned a few, but, just to reiterate some other ideas or add-ons that you briefly touched on.
Besides diet, activity, the brain exercises, I'm going to go back to physical activity, especially physical activity that's been studied, researched in our aging population, and that is Tai Chi. Balance is really important. And I say this because we often see people who have issues with balances. There may be a physical reason for it, there may be a medical reason for it that's not necessarily addressed because, oh, I always catch myself. I like walk using the furniture or the walls or whatever, and I haven't fallen. But when that fall happens, unfortunately, it's very painful. And we have to give drugs to alleviate the pain. And some of those drugs can cause delirium, which can get confused for dementia. And so we often see people misdiagnosed with dementia when all it was delirium because of a drug effect, because of pain, because of constipation, because of the drug. So one thing after another, it just kind of snowballs. And then eventually this person is not moving and grooving like they were, whereas they were grocery shopping and driving 6 months ago. So very quick changes can happen in a matter of months. And families get overwhelmed very quickly and are looking for answers. I don't think all of community services families are as easily triggered by this as what I see in the mainstream communities that I deal with. But nevertheless, I think it's really important to be standing on your own 2 feet firmly for as long as possible. So go do Tai Chi, make it a regular practice, do it at all of community services, do it at your YMCA, do it with Silver Sneakers, do your sit and be fits because what they're doing is they're strengthening your quad muscles, which are your thigh muscles. These are giant muscles that are holding you upright. Those and your core, so your stomach and your back, these are going to hold you upright for a lot longer and keep you strong. So if your body does try to fall, you catch yourself. Because I find that that is the most common reason coming up now is accidents. Accidents kill our children and our elders very often. And so, what I don't want to see is somebody getting misdiagnosed with dementia when they just needed a little bit of time, but in our go, go, go society and go, go, go healthcare system, which is not really a system, you're going to get lost in that. And I think it's really important to strengthen that middle part of your body, like between your knees and your chest, like your rib cage, that portion. If you can keep that as strong as possible for as long as possible, then you're less likely to succumb to an accident that is going to get you misdiagnosed with dementia. So that's the only thing I can think of.
I love how you mentioned Tai Chi because that's something we encourage our seniors, and we don't personally offer it, but we partner with the city of continuing education. Like they offer a Tai Chi 2 hour Tai Chi and balance class at the West Anaheim Youth Center on our Wednesday program, and we piggyback off it. So we encourage people to attend that as a group, and then we do a 2 hour activity right after. So people have been actively engaged, and there are 90 plus year olds in that Tai Chi
Mhm.
class. So if you're thinking it's not for everyone, it definitely is.
Yes,
Another
absolutely.
question, is dementia hereditary or a combination of environmental and hereditary factors?
Okay, it's a combination. Yeah, there's not one or another. So if you have a genetic mutation, you're at a higher risk of developing it earlier. So that's kind of what we see in our early onset dementia patients. They usually have a genetic mutation. So they're showing, I mean, the youngest patient I ever had was 48 years old. That's a year older than me. So he was really, really young, but he had the genetic mutation. I believe one of his kids had it as well. We don't know about his parents because we didn't have the genetic testing at that time. But again, that is in early onset. Then in other types of dementia, you can have the gene, but if you live a very clean lifestyle, you never smoked, you never drank, you exercised, you ate right, you did everything good, even with that gene, we don't see the dementia until very, very late in the game. Like I'm talking like you're 80, 90, you got sick, and then, oh, now you don't know what's going on. And that again is more delirium than it is dementia, you know? Delirium is a temporary condition and delirium is reversible. Dementia not is not. So it is always we see more than 90% of the time is going to be a combination of genetic and environmental factors.
Sure. Someone mentioned, I have seen caregivers suffering taking care of their loved ones. There is no quality of life but a burden. What is the solution for people who come from different faiths, backgrounds at the same time? There's a sense of obligation, our faith and culture might, it's different. It's, this boundary setting is not very common, especially with our elders, right? Like it's a new concept. You feel like you're selfish if you're like, I need some self-care time, or the caregiver, what do you call, I'm forgetting the word myself.
Caregiver burnout.
Burnout, yes, is a thing. So
Yeah.
any thoughts on that, Uzma?
I have so many thoughts on that. I have so many thoughts on that. So, for those of us who have experienced parenthood, uh, parenthood is 24/7. Yes, for the rest of our lives, but literally 24/7, those first couple of years of a child's life, right? The 2 years of like sleeplessness because this thing will die without you. Like they cannot eat, they cannot go to the bathroom, they can't keep themselves safe, they can't keep themselves clean without you. That's 2 years. And this person has a life expectancy of it's growing, average is 83, but it's getting, as we're getting better drugs and better treatment and better awareness, they're going to live a long time, but only 2 years. I had to do that with the kid. But now I'm telling you, somebody with dementia can live up to 25 years after diagnosis. 25 years, you ask somebody 24/7, work for a child for 2 years. Okay, fine. But 25 years to do that work 24/7, you will die. Like you will die. And we often see that where caregivers are like doing everything 24/7 for this person. And what's going to happen when they drop dead? Who's going to take care of this person like that? Nobody. Nobody is expected, regardless of religious, cultural, or social obligations or perceived obligations, I will say, to take care of somebody like that. Everybody must take care of their own needs. We have the concept of, oh, I have to put on my oxygen mask before, I put it on other people because if I die, how is this person going to get their oxygen mask on? Yes, that can be taken to a whole different, very Western level. But I think there is a lot of Eastern wisdom in it too. Like we do need to take care of ourselves to get educated, to find out resources, and yes, to take care of ourselves and maximize our own health so that we can be the best version of our caregiving selves to our loved ones. Um, no, we don't draw great boundaries. Where most of olive community families come from, there is no such thing as boundaries. And for some reason, we think there's trophies for sacrifice. And the more we sacrifice, the bigger the trophy. And then the trophy never comes and we get really mad. There's no trophy, okay? There's no trophies for suffering. That's not what I think any God would want for their followers. So I think it's really important to, at the very basic level, connect with peers. The Alzheimer's Association is kind of like Alcoholics Anonymous. They have meetings all the time, everywhere, for everyone, in all kinds of spaces. And if you have a space that you like and you feel comfortable with, then you should tell them, hey, can you have a meeting? We can have this many people here. Will you come and help facilitate a peer support group. These peer support groups are really, really important so that you can learn how somebody else is setting boundaries without compromising those perceived social cultural obligations. Well, if they're able to go out to dinner once in a while, or if they're able to take a vacation and figure out how so and so takes care of their, or who's going to take care of their spouse while they're gone, or if they found resources for respite care for their loved ones, how am I going to, and amongst yourselves with other caregivers who are going through the same exact things, you can come up with amazing solutions. And most importantly, you can lose some of that guilt, some of that perceived burden, or that burden that you've created and put on yourself to be the 24/7 person to take care of this one. Because we're not meant to take care of anybody 24/7 more than that 2 year period. It's really impossible to do. And we're looking at decades. So if you want to last for decades taking care of this person and having a good quality of life yourself, you really have to invest in the basic level peer support. At least with Alzheimer's Association, because that's a resource that's already out there. If Olive is available to facilitate any of that, then through them. And then I will say there are times when family is not the safest place or home is not the safest place for somebody with dementia. This is a case by case basis. But there are times when it's not the best. And we actually see dementia people getting better when they're in devoted units for dementia care. Because those people that are taking care of them 24/7 are highly trained. They're working on shifts. So you have like two, three people that are coming in every day, fresh start, ready to go. They know this person's routine. They also know, hey, I have to take them to this activity. I have to take them to this excursion. I have to feed them these foods, do these exercises. Sometimes dietary and cultural compromises need to be made or concessions need to be made. But overall, like you'll see somebody kind of languishing on their own or in their home, and then they come to a memory care and it's like, wow, this is so cool. It's a change of environment. I'm doing really well because that routine is super duper important in memory care. And families don't always realize that. And families, as well meaning as they are, sometimes will do trivia too late and they'll come in for Eids or they'll come in for Christmas and Easter or Thanksgiving because that's the only time they see their loved one. They'll be like, "Do you remember that thing, that time that we did?" Da, 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 da. Early on, maybe you can do that, but like middle, late stage dementia, if you're doing that, you're making somebody feel really, really bad about themselves. And you don't even know that wasn't your intention. You're just trying to make a connection. But you're making them feel bad about themselves because they know they can't remember. And now you're testing them. So these kinds of things you learn by being with peers, going out and getting continuing education about dementia care and dementia support as a caregiver. So I think that those are really key ways to support yourself as a caregiver. And it's really important to let go of, this cross that you don't have to bear. Like nobody deserves that and nobody expects you to do that. It's just not sustainable.
For sharing. Ismet,
Yes,
I believe you have a question. Go ahead and
I
ask.
wanted
Go
to
ahead.
ask a question.
Yes.
I thought I would be able to explain that better when I talk to you. Uh, I'm over 80, like I'm 80 plus.
Sure.
I feel that I'm forgetting now. I don't forget everything. I remember certain things very clearly. But I wrote, Zainab will be there. I think she will have observed more because I travel with her to olive events. So I feel that I'm forgetting things. Is this a time when I have to go to a doctor to get myself checked? Am I a candidate for, am I, in the initial stages where I can check myself with diet and other things so that it doesn't progress that fast?
Yeah, I would say if you are independent and functioning independently and you're concerned at all, you should go get tested. It's just an office visit. There's absolutely nothing invasive about it. And to be concerned, I think, is to be uh, progressive, yani preventing anything from happening is always, always better. Because again, there's no cure for dementia, right? So the earlier you catch it, the better. So if you're already suspecting something, it's a good idea to go to your doctor and say, hey, I'm worried about my memory. What can we do?
So which doctor have I to go to? My PCP?
Yeah, I would start there. And then if they find anything on the initial testing and like, oh, okay, like maybe this lab explains a little bit of what's going on, but I don't like what your cognitive tests were. Why don't you go to neurology? They may do that. They may also suggest you go for neuropsychological testing. This is a battery of tests. It's exhausting. It's 3 hours long. But these are tests that are way, way longer than the mini mental status exam and the MOCA exam that I mentioned earlier. But I think that they're really, really necessary because they test different cognitive functions and cognitive exercises we all do, but we take for granted and we don't know the names of them. But these tests kind of tease it out. And in addition to brain imaging, because neuropsychological testing also includes advanced brain imaging like the MRIs and the PET scans we talked about. And so what they're trying to do is with the tests results they do in that 3 hour battery and with the imaging is combine and figure out exactly where in the brain there is a deficit so that they can tease out what predominant dementia do you have. And then we can figure out from there what we need to do for lifestyle modification and drugs.
Like, we have cancer screening, breast, like mammograms and other things. But why don't we go in after a certain age? Why doesn't everybody go for a test like this so that, the thing is caught right early in?
We don't have any, so the USPS task force gives us preventive guidelines in the United States on what to test for that's more likely to kill you. But, really until I think it was 2020, our baby boomers hadn't aged in, so we hadn't worried about them. We are a very ageist society and culture in America, so we don't care about our elders. So why would we screen for something that we don't care about? We're not going to treat, we're going to cut Medicare dollars for anyway, right? It's really hard to get approved for some of these experimental drugs for dementia, by the way. But I don't know why people don't do it. As a geriatrician, everybody 65 and anybody I see for the first time always gets a mini mental because I'm screening everybody. This is why I think it's important to get a geriatrician because that's kind of our training, right? Like we're looking for these kinds of things that are going to compromise your function and your cognition because we want to make sure that we preserve those as long as possible.
I do want to add that I learned about every person who has Medicare, they get an annual Medicare wellness visit. It's called AWV. It's not necessarily a physical exam, but it's like how we had wellness baby appointments when our newborns were born. So I think those are good opportunities to bring this up. Like, can you do my memory test or something and share? Maybe I'm just throwing it out there. That's something I learned that's covered by your Medicare coverage. Everyone has a right, and sometimes people don't know, and they only go to the doctor when they're sick. So I'm just letting you know it's called a wellness visit that you can demand. Since we have only a few minutes left, Uzma, I'm going to throw questions at you.
Yeah,
You can
yeah.
popcorn your answers. That would be wonderful. Okay, here we go. Obviously, everyone's loving this presentation, finding it very helpful. What are some herbs and spices that are helpful in dementia preventative diet?
Turmeric.
There you go.
Turmeric. Anti-inflammatory. It comes in a
Does
capsule
the
form.
pill
Add it to all your food.
does the pill versus the powder or the whole food make a difference in terms of?
I don't know the answer to that in terms of the research because the research is coming out of India primarily from our Ayurvedic practitioners. So I don't know. I put it in all of my food. Nobody in my family has dementia, but I like put it in everything. Maybe
Right.
yeah, except desserts. It goes in everything. But I would say capsules are readily available over the counter. I don't
Yeah.
know the most effective dose to prevent dementia, but it's not going to do anything. It's anti-inflammatory. I think everybody should take it.
Mhm.
No known side effects, except it turns stuff yellow. So if you're using the actual powder form, like don't let it fall on your counters and don't get it on your skin.
And brush your teeth.
Oh
So
yeah.
your dentist doesn't get upset.
Yes, exactly.
All right. I love Olive's bus trips in transit with play fun mind games. So they're just sharing that they love that.
I'm
What
glad you
type
do
of
that.
blood test or other tests can provide an early indicator of dementia? Anything like that?
The genetic tests that are looking for those specific genetic mutations that I listed on the earlier slides are a good one, but a basic panel is absolutely important to rule out any other metabolic cause that could be either masking dementia or making it seem like you have dementia when you really don't. So complete blood count, complete metabolic panel. I always check a thyroid panel because sometimes if you're not treating your thyroid, you can look like a dementia patient, you can act like a dementia patient, but you don't have dementia. All we have to do is treat your thyroid and you are fine. B12 deficiency also can act just like a dementia. We give you the B12 and you are fine. What else do we check for? Yeah, that's my basic panel that I look at.
That's great. I wanted to also add that one thing we learned at our health fair is every county has a caregiver resource center, by the way, that has great resources. They sometimes have grants for respite care, meaning you can take a few days off despite your income level. You just have to go through the process of applying. So just throwing it out there. I think Naziha, you have a question. That will be the last one. And to respect our speaker's time, go ahead, speak ahead.
Okay, I have a question about the genetic mutation test. Is this covered by insurance?
Depends on your insurance. I would say if you only have straight Medicare, probably not. And you probably need to have some kind of secondary insurance in order for it to be covered.
Yeah. They
And you
don't do that.
you'll have to have your doctor will have to make a case like, hey, this was abnormal and this was abnormal and this was abnormal, and we want to rule out a genetic basis for this.
Okay.
So you're going to have to go through quite a few steps and probably the neuropsychological testing, that 3-hour long battery as well, in order to prove that there is a need for your insurance to cover it. And if you have United, it probably will get rejected.
I have scan and it is just straight, what do you call
Straight
it?
Medicare.
Medicare, yeah. So
Yeah.
So yeah, they wouldn't probably.
Yeah, it's going to be really hard.
Maybe I can get supplement.
I'm not a big proponent of insurance, period, because I think private insurance is a scam, and that's why it particularly kills our oldest old and our sickest sick. So yeah, I hate it.
Oh,
Yeah.
I agree.
But you'll have to talk to an insurance broker and your
Right.
neurologist. Yeah.
Thank you.
Absolutely. My pleasure.
Right. I think this is a great session that, first of all, first time meeting a geriatrician. So I think all our Olivers are appreciating that, specialty that we may not even know exists out there. So I hope you all feel empowered with the term. I love how Dr. Jafri is keeping it real, be it dementia, be it debt, be it all these terms. I mean, embracing aging with grace comes in all shapes and forms. There's a lot of topics she talks about, by the way.
Yes.
Some may be taboo, some may be, very comfortable or in our bubble type of topics. And I'm happy to share that Dr. Jafri and I got to talk on her podcast. So then maybe that will be coming up. So you'll get to hear that too in the future, as she does a great job covering different topics, different age groups and their issues. So Olivers, we're at 12:01. Thank you, Dr. Jafri again. This recorded session will be shared on our YouTube in give me a few weeks at least, if not more, and then we will be back with another dementia topic, I think in June or so, I believe, is our next one. Thank you, Dr. Jafri, again for your time.
Olive Community Services is a 501c3 nonprofit organization based in Southern California that provides culturally appropriate services to seniors, their family, and the community. Through its physical and virtual interactive programs, Olive engages participants in a variety of ways that promotes health and well-being. To learn more about Olive Community Services, to get involved, or to make a donation, please visit www.olivecs.org or email info@olivecs.org. Be a change maker, and together, let's live, learn, and thrive.